Now we have to move on to the details of the trunks. Where the trunks are, the roots and trunks are in the neck region. And how many trunks are there? 3 trunks. Which 3 trunks? Upper, middle and lower trunks. So let us talk about them. This is the upper, middle, lower trunk now. Yes. As we're talking about the 3 trunks of brachial plexus, which will be actually in the neck region, we need to discuss more details about them. And you see here is the schematic diagram we were using. So there are 3 trunks. Yes, you see there are 3 trunks of brachial plexus in the neck region. And how they are formed? Actually, there is the root value C5, 6, 7, 8, T1. They'll be contributing. So who is contributing? It is the root of C5 and root of C6, which will be forming the upper trunk of brachial plexus. Whereas the C7 root value will continue as the middle trunk of the brachial plexus, and the lower 2, which is C8, T1, the C8 and T1 will join to form the lower trunk of the brachial plexus. Then you will find that there are 3 trunks in the neck region for the brachial plexus, and there is a question asking what are the branches? Branches of the trunk? Yes. You see, there are 2 branches in the upper trunk. Name, there is a suprascapular nerve and the nerve to subclavius. But then, if you remember, we have discussed the suprascapular nerve, sublime scapular muscles already. We did not discuss this nerve to subclavius. Yes, that is why a question has come regarding that. What is the question regarding that? They're asking upper trunk is giving which branch? And your first answer should be suprascapular nerve, and the second answer should be nerve to subclavius, because there are some books which will say nerve to subclavius come directly from the roots of the brachial plexus. So you mean to say when I have to choose between the 2, both can be the answer from the upper trunk of brachial plexus? Yes, but this is suprascapular nerve first answer and nerve to subclavius second answer, because it is mentioned that nerve to subclavius may come directly from the roots of brachial plexus. And what about the middle trunk and lower trunk? Middle trunk, lower trunk don't give any branch in the neck region. So which question you were talking about? I'm talking about this question. It is asking branch from the trunk of brachial plexus. And only upper trunk is giving branch? Yes, not the middle and lower trunk. So upper trunk giving 2 branches, that's why we have 2 answers. Yes, you have 2 answers, which is your first one. It's a lot of controversy because in 40th edition of Gray's Anatomy something is given, and in 41st they are reversing it. So 40th edition of Gray's is giving this and 41st is giving that. Yes. So even Gray's Anatomy don't know what is the correct answer. Yeah, they keep changing it. So what is the present answer? I told you already. C is a better answer than D. Why C is a better answer than D? Earlier you were telling D is a better answer than C. I told you. There is a lot of controversy. In 40th edition it is given this way, and in 41st it is given that way. So you mean to say this is the present answer? Yes. That's why you should read from the latest books always. This is the present answer. Latest edition, 41st edition of Gray's Anatomy. Now C is better than D. You mean to say nerve to subclavius is a branch from the trunk of brachial plexus, not the suprascapular? That I don't know. Actually, both are in fact. But C is better than D. Yeah. Okay. What about the Erb's point? There's a question on Erb's point. It is meeting of 6 nerves. So which 6 nerves are meeting can be discussed? Yeah, let us discuss. See, there is an upper trunk, middle trunk and lower trunk. Yes. You will see that in the territory of behind the clavicle, there will be some divisions. What divisions will be passing behind the clavicle? There is a anterior and posterior division of the upper trunk, and anterior posterior division of the middle trunk, and anterior posterior division of the lower trunk. You mean to say I have 3 anterior division and 3 posterior divisions? Yes, there are 6 divisions passing behind the clavicle to enter the axilla. So what is Erb's point then? Erb's point is in the territory of the upper trunk and is 6 nerves meeting point. Which 6 nerves are meeting here? It is the root of C5 and root of C6. And it is the suprascapular nerve and nerve to subclavius. And it is the anterior division and posterior division of upper trunk. So can you tell me the 6 nerves again? The 6 nerves at the arch point? Yes, they are. Root of C5, C6? Yes. And the suprascapular nerve, nerve to subclavius? Yes. Anterior division, posterior division of upper trunk? Yes, that is the arch point. Now, what is the importance of arch point? If it is damaged, there will be arch palsy involving root value C5, 6. And which muscle compromised? Any muscle which is supplied by the root value C5, 6. And which nerves could be they? There are 2 of them. And further, they are here. You mean to say musculocutaneous nerve, axillary nerve, radial nerve, and medial nerve? Yes. And not the ulnar nerve? No. Why not the ulnar nerve? Because ulnar nerve do not have C5, 6. Oh, it is not involved? No. So who is involved? Whatever nerve has the root value C5, 6 is involved in arch palsy. Also remember one thing. Wherever the injury is, only distal area is involved, not the proximal area. So means if this is the injury level, then distal nerves will be involved, not the proximal nerves. No, not the proximal nerves. Like which nerve are you talking about? See, this is long thoracic nerve to serratus anterior, and it is already given directly by the roots of C5, 6, 7. So long thoracic nerve to serratus anterior directly come from the roots of C5, 6, 7 is already given in the neck region. Yes. So it will not be involved. No. Most of the cases of arch palsy, it is not involved. Why? Because it is already given and injury was distal to that level. So only distal area involved, not the proximal area. It's still working. So this is the arch point. Yes. Which is root of C5, C6, and then you have suprascapular nerve, nerve to subclavius, and then you have anterior division, posterior division of the upper trunk. Yes, it is the territory of upper trunk. If it is involved, then there will be arch palsy with root value C5, 6 injury. Muscles with C5, 6 will be paralyzed. So, you are talking about the lesions now. Yes, arch palsy. And I will be comparing it with the clump case palsy. So, you want to compare arch palsy with clump case palsy. I think we have learned earlier that it is C5, 6 root value involved. Yes, that's why the proximal muscles like shoulder and scapular muscles involved, leading to difficulty of shoulder abduction. And what if the clump case palsy? Then the distal root value, the hand muscles involved, which is C8, T1. And if a C8, T1 is involved, then the problem will be the claw hand deformity. There you have claw hand deformity, and here you have policeman tip hand deformity. So there is some policeman tip hand deformity in arch palsy. Yes, due to some muscles not working. So can we discuss more about them? See, if you are trying to do the shoulder abduction, it is done by the shoulder muscles and scapular muscles, so they might be compromised, and difficulty abduction. Also, difficulty elbow flexion. Why elbow flexion difficulty? Because C5, C6, you know. Oh, so elbow will remain in extension. Yes, because that time the C7, 8 radial nerve or triceps will be more powerful. So because C5, 6 is involved, elbow flexion is a problem. Yes. So then the elbow will remain in extension. Yes, because C7, 8 will be more powerful. You mean to say triceps is more powerful and biceps is paralyzed? Yeah, this is arch palsy. Similarly, if the patient cannot do shoulder abduction, then the shoulder will remain in adduction deformity. So there will be adduction deformity. Yes. And there will be elbow extension deformity. Yes, that is arch palsy. Let us discuss more details. You see, in clump case palsy, it will be the other way around. What is that? What is the root value involved in clump case palsy? C8T1. So finger flexion can become a problem, and finger spreading, closing is a problem. So there will be a claw hand deformity. Claw hand deformity, why? Because hand muscles are paralyzed. Can we discuss more about that? Yes, we'll discuss, but here we draw a diagram. Here we draw a diagram which is going to tell us the details of the two. So we are going to talk about the roots of the brachial plexus, and which are root value C56 and 78 and T1 also. So 5 root values of brachial plexus. Yes, C56 and 78 T1. And then I will show the trunks here. But when you're talking about the trunks, they will be in the neck region only. So roots and the trunks are in the neck region only. Roots also, what you are telling is anterior primary ramus of the C567T1. So what are they doing? You already know that the root of C5, C6 will join to form the upper trunk of brachial plexus. This is the upper trunk of brachial plexus. And then C8, T1 roots will join to form the lower trunk of brachial plexus. I am showing one on each side. On the right side, I am showing upper trunk, and on the left side, I am showing the lower trunk. Then what about the middle trunk? Middle trunk has the middle value. And what is the middle value? That is C7. So C7 is the middle value for the middle trunk of brachial plexus. Yes, C7 for the middle trunk. I think the upper trunk gave 2 branches. Yes, upper trunk gave 2 branches. If you remember, their names were. I think there is a suprascapular nerve supplying the scapular muscles. Yes, and there's nerve to subclavius. Correct. There's a nerve to subclavius and suprascapular nerve supplying scapular muscles, and with the proximal root value, which is C56. Compromised in Erb's palsy. Whereas C8T1 will be compromised in, it is compromised in Klumpke's palsy. Now remember, when the baby is developing, it is developing such way that this is the head and the trunk region, and this is upper limb and the lower limb region. So this is the head and trunk region. Yes. And that is the upper limb and lower limb region. Yes. What do you want to know here? You have to understand that there are proximal muscles like shoulder scapular muscles. The proximal muscles like shoulder scapular muscles, they will have the proximal root value, which is C56, which are compromised in Erb's palsy. Whereas, if you are talking about the distal muscles, which are hand muscles, then they have distal root value, which is C8T1. So that will be compromised in Klumpke's palsy. So you're telling that proximal muscles like shoulder scapular muscles have proximal root value, which is C56, will be compromised in Erb's palsy, and distal muscles like hand muscles will have distal root value, which is C8T1, will be compromised in Klumpke's palsy. Yes, let us compare the two now in the diagram. And as you do so, you will find that this is the injury in Erb's palsy. So when we are talking about the Erb's palsy, it is actually injury to the upper trunk of the brachial plexus. So when the upper trunk of the brachial plexus is compromised in Erb's palsy, what will happen? You will see that the muscles with the root value C56 will be compromised. And who are those muscles? Those muscles are the shoulder and the scapular muscle. And what will happen if the shoulder and the scapular muscles are compromised? Then you will see there is a deformity which is called policeman tip hand deformity. If you say it is the policeman tip hand deformity, then can we explain about this deformity, why it has happened? Because some muscles are paralyzed and some muscles have become more powerful, unopposed, bringing the deformity. So which muscles are paralyzed? Any muscles with the root value C56. Any nerve with the root value C56 compromised. Like you are telling that suprascapular nerve to subclavius compromised. Yes, and more than that, any nerves which is coming distally from C56. What about the nerve to subclavius? What about the nerve to serratus anterior? If you are talking about nerve to serratus anterior, it came directly from the root of C567. So what about that? It is called as long thoracic nerve to supply serratus anterior. As we have learned that the long thoracic nerve to supply serratus anterior would have come directly from the roots of C567. So it is not involved in Erb's palsy in most of the cases. Most of the cases of Erb's palsy, injury to the upper trunk, the long thoracic nerve to serratus anterior is not involved because it's already given before the level of lesion in the neck region. So it is not involved. What will happen if I have injury to long thoracic nerve to serratus anterior? If I have injury to long thoracic nerve, then serratus anterior will be paralyzed and leading to winging of scapula. That results in winging of scapula. Injury of long thoracic nerve. So, what was there in the Erb's palsy? In Erb's palsy, we had this policeman tip hand deformity. And what about the Klumpke's palsy? If you want to discuss Klumpke's palsy, then you have to talk about the lower trunk injury. And what is lower trunk injury? That is the Klumpke's palsy there. So, what will happen in Klumpke's palsy when the lower trunk is involved? When the lower trunk is involved and there's Klumpke's palsy, the hand muscles will be compromised. If you say the hand muscles are compromised, then I can say that it is lumbrical interossei paralyzed. Yes. And when the lumbricals and the interossei are paralyzed, you will see that they will be leading to what is called as claw hand deformity. Now we have to discuss the claw hand deformity in detail. And then we also have to discuss the Erb's palsy in detail. So claw hand deformity comes because there is paralysis of some lumbrical interossei. Yes, C8, T1 root value involved. Chiefly which one? Chiefly T1. Whenever there is a choice given to you, whether it is C8 or T1, it's always better that you answer T1. Klumpke's palsy is more to injury to the T1 rather than C8, though it is C8, T1 together. Okay, fine. Then what about the clinical features of Erb's palsy and Klumpke's palsy? We have to discuss those now. As you continue with that, you will find that we are first looking at Klumpke's palsy, which is a table. In this table, we'll find that there is injury of the lower trunk and any nerve with the root value C8, T1 involved. That could be ulnar nerve, but it is also partial injury of median nerve. Why median nerve? Because median nerve has all the 5 root values and it is partially injured. So ulnar nerve is injured and median nerve is partially injured. Yes, there's also injury of T1 root value carrying some sympathetic fiber. So T1 root value carrying sympathetic fiber. Yes. Okay. So what could be the etiology? Why there is a Klumpke's palsy? It could be a birth injury or sports injury. What kind of birth injury can lead to Klumpke's palsy? There was a difficult labor and you are trying to pull the baby out and there is a hyperabduction injury. So mother was in difficult labor and you are trying to pull the baby out to prevent ischemia to the brain of the baby. And in that process, you are doing hyperabduction injury. So which trunk is pulled? The lower trunk of brachial plexus is pulled, leading to Klumpke's palsy. And this is sports injury. What is happening? It was a boy playing and falling from a tree, trying to hold the branch. So this boy is falling from tree and trying to hold a branch. What happened? Hyperabduction injury and lower trunk is pulled, leading to Klumpke's palsy. So what is happening? There is a claw hand deformity. Why there is a claw hand deformity? Explain. First you have to look at the normal thing and then the abnormal thing. There will be the Horner syndrome also. Horner syndrome. Why? Because, you know, T1 root value involved. T1 root value involved. T1 sympathetic root value involved leading to Horner syndrome. Yes. Okay. Fine. What about the clinical features? I told you there are 2 clinical features which you have to remember. One is the ptosis due to paralysis of a smooth muscle, which is the superior tarsal muscle, part of the Miller muscle. And what is the other thing? Other thing, there was this smaller pupil which is called as meiosis due to paralysis of sphincter, the dilator pupillae. So when the dilator pupillae is paralyzed, the sphincter pupillae became more powerful, leading to meiosis. That is a Horner syndrome in Klumpke's palsy. Okay, these 2 muscles paralyzed. Yes. And the other muscles become more powerful. Yes. Okay. What about the claw hand deformity? As you want to talk about the claw hand deformity, you will see that is claw hand deformity. What is this? Actually, you have to understand that MCP flexion and IP extension, yes, The MCP flexion and IP extension is done by the lumbrical and interosseous together. We will discuss this later as well, but remember that when we are talking about MCP flexion and IP extension, that is done by lumbrical and interosseous together. So what if they are not working? If they are not working, then you will see that MCP joint goes into extension, MCP extension. So MCP joint will go into extension, yes, and IP joint will go into flexion. IP joint will go into flexion, and that is called as the claw hand deformity. So telling that in clump case palsy, since the lumbrical and interosseous are not working, there's a problem with MCP flexion and IP extension. Yes, and the other muscles became more powerful. Yes, that's why you see MCP, which cannot be flexed, will go into extension, and IP, which cannot extend, will go into flexion. Oh, like that. Yes, that is called claw hand deformity. We'll discuss about it later as well. And what about the Erb's palsy? When we are talking about the Erb's palsy, we got a table for that also. And what is this table telling? It is telling that there is injury to the upper trunk, which is root value C5-6, and some nerves are compromised, like you have the suprascapular nerve already mentioned by the upper trunk, and there is also the axillary nerve, muscular gradient nerve, radial nerve, and some more nerves with the root value C5-6. Radial nerve is also damaged. Yes, actually radial nerve has all the 5 root value. It will be a partial injury of the radial nerve. What is partial injury of radial nerve? Explain. That we will do. But at this moment, see what is the etiology. What is the etiology of Erb's palsy? Again, birth injury and sports injury. What kind of birth injury? Actually, mother is having difficult labor and you're trying to pull the baby out. And there is undue separation of the head and neck. So the mother was in difficult labor and we are trying to pull the baby out, and there is undue separation of head and neck. Which trunk will be pulled? That will be the upper trunk of brachial plexus, which is pulled. So leading to Erb's palsy. Yes. And similarly, this is a sports injury. Why? What happened? There was a fall on a shoulder. And what will happen when there's a fall on shoulder? Again, undue separation of the head and shoulder. So when there is an undue separation of head and shoulder, then which trunk is pulled? That is the upper trunk, which is pulled. So Erb's palsy. Yes. What is the deformity in Erb's palsy? This. What is this? It is policeman tip hand deformity. Can we discuss this policeman tip hand deformity now? Yes, you have to discuss it. It is a problem at least at 3 joints. So 3 joints and more. We have to discuss the 3 joints now. So let us do it. Yes, let us do it. Also, you will see that there will be some sensory loss on the lateral aspect of the upper limb. Why lateral aspect of the upper limb? Because C5-6 dermatome involved. Oh, and what is this dermatome? This is called as the regimental batch anesthesia. So regimental batch anesthesia means what is the dermatome? It is axillary nerve C5 dermatome, skin on the upper part of the deltoid. So skin on the upper part of deltoid muscle. Yes, skin on the upper part of the deltoid is having sensory loss, and it is called regimental batch anesthesia. There. So because of axillary nerve involvement, yes, this is one question which is coming. In Erb's palsy, there is sensory loss to the lateral aspect of the upper limb, including this particular area. Okay, let us make some diagrams for the Erb's palsy then, and you'll see it is injury of C5-6 root value. As the C5-6 root value is involved in Erb's palsy, you will find that there are many nerves involved, and we are discussing 3 of them. So which 3 nerves are you discussing? I'll be talking about the axillary nerve, and there is also injury to muscular gradient nerve, and then there is also injury to the radial nerve. Radial nerve is also involved. Yes. In fact, you have to understand it is the total injury for the axillary nerve and partial injury for the next 2. But why would you say it is partial injury for the next 2? Because you have to understand the axillary nerve root value is C5-6 only, so it is totally compromised, and in Erb's palsy, it is totally compromised, and since musculocutaneous nerve has C567, maybe 5-6 involved, but the C7 is still working, and some muscle may be still working. So you are telling that Erb's palsy is problem of C5-6, so it is a partial injury of the musculocutaneous nerve? Yes, because only C5-6 root value involved and C7 may be working and some muscle may be working. Similarly, the radial nerve has all the 5 root values of brachial plexus, and because it has all the 5 roots of brachial plexus, only C5-6 compromised. And because only C5-6 compromised, C7-8 T1 working, and because C7-8 T1 working, some muscles may be working, some muscles will be paralyzed. So, which muscles paralyzed then if it is a partial injury of radial nerve and musculocutaneous nerve? First you start with the total injury of axillary nerve, number 1. So, we start with axillary nerve. Yes. Okay, what about that? See, it is a total injury of the axillary nerve. So, because it is total injury of the axillary nerve, there is total paralysis of 2 muscles, namely that is the deltoid muscle and also the teres minor. So, what is deltoid muscle doing? Deltoid muscle is a powerful abductor at the shoulder joint, and teres minor, it is a lateral rotator at the shoulder joint. So, there will be a difficulty at the shoulder joint that the patient is finding difficulty for shoulder abduction, and there is also difficulty lateral rotation of the shoulder joint. And what other problems will be there in Erb's palsy? You will see that there is one more nerve involved, which is musculocutaneous nerve, but musculocutaneous nerve was partially injured. If you say it is partially injured, can you tell me what does that mean? Actually, this is having root value C567, yes, and supplying 3 muscles. Which 3 muscles? Musculocutaneous nerve is having 3 root values, supplying 3 muscles, and their names are, yes, one of them is called coracobrachialis. And what about the coracobrachialis? Actually, coracobrachialis muscle supplied by musculocutaneous nerve has all the 3 root values. So it may not be paralyzed. Why it may not be paralyzed? It may not be paralyzed because you see, in Erb's palsy, which root value involved? The C5-6. So which is still working? C7. So it may be still working. You are telling that it is musculocutaneous nerve having 3 root values and taken by the coracobrachialis, so it may not be paralyzed. Yeah, because of C7 still working. It's a partial injury of musculocutaneous nerve. Some part of nerve still working. Some muscle may be working. Then which muscle not working? I told you it is supplying 3 muscles. The other 2 are not working. And who is the other 2? You will tell they are the biceps brachii, which are paralyzed. And what is the other one? It is the brachialis muscle which is paralyzed. If you say the biceps brachii is paralyzed and the brachialis is paralyzed, then I think their major value is C5-6. Yeah, that's why. Because their major value C5-6, they have been paralyzed, and there is a difficulty of what do? They are doing elbow extension, elbow flexion. They are doing elbow flexion. So there will be a problem of elbow flexion. And there is one more problem. What? See, biceps brachii is a powerful supinator also. And because it is a powerful supinator also, there will be difficulty in supination. There is a difficulty in elbow flexion and also supination. In fact, the biceps reflex is lost with the root value C5-6. In Erb's palsy, the biceps reflex will be lost with the root value C5-6. And one more reflex is lost with the root value C5-6. Which other reflex is lost with C5-6 root value in Erb's palsy? Let us discuss. You know, the third nerve was the radial nerve, and radial nerve was having partial injury. When you say radial nerve was having partial injury, what does that mean? That means some muscles are paralyzed and some are still working. Which are paralyzed? See, radial nerve is having a problem with root value C5-6. So the muscle with root value C5-6 compromised, the name of that muscle is brachioradialis. Now, if you say brachioradialis muscle is paralyzed, this is the muscle which is doing the elbow flexion in mid-prone position. Elbow flexion in mid-prone position. So this is the muscle for elbow flexion again. Yes. In mid-prone position. Yes. Mid prone position. So it will be compromised. Yes, one reflex is also compromised, and that reflex is called supinator reflex, carried out by this muscle. Supinator reflex has the same root value as the biceps reflex, so both are lost in Erb's palsy. So supinator reflex is carried out by the brachial radialis muscle and having the same root value as the biceps reflex. Both are lost. Yes, and one deformity will be there. Let us discuss the deformity. In Erb's palsy, there is policeman tip hand deformity, which can be explained at 3 joints. And what are the 3 joints involved? You see, there was a problem at the shoulder joint. What is the problem? At elbow joint then. And there's also a problem at the radio-ulnar joint. So what is the problem at the 3 joint? What is the problem at the shoulder is abduction and lateral rotation. And what about the elbow? Elbow, there is a problem of the flexion, and radial ulnar joint, there is a problem of supination. So these movements have become weak, and because these movements have become weak, the other muscles and other movements will become more powerful, bringing the deformity, and that deformity is called as policeman tip hand deformity. So this is policeman tip hand deformity. Yes, somebody saw police people taking money like that. Why they take money like that? You take money like that and it is immediately put into pocket. It is a short movement and you don't want to get noticed. That is the reason. So take money like that, bundle of currency, yes, and bundle of currency goes into pocket now, like that, yes, and the short movement, so nobody will notice, yes, that is why. So policeman tip hand deformity, yes. Can you explain policeman tip hand deformity now in the patient? Yes, of course. You know, there's a problem of shoulder abduction, so shoulder will remain in adduction. There's a problem of lateral rotation, so shoulder will remain in medial rotation. You mean to say if abduction is not happening, the adductors are more powerful? Yes. And if lateral rotation is not happening, then medial rotators are more powerful? Yes, that is the point. And what is the other thing? Other thing, you see, elbow flexion was a problem. So extensor triceps is more powerful. So elbow will remain in extension. So you're telling that the flexors are compromised and the extensors are more powerful? Yes. Similarly, the hand find difficulty in supination because biceps is compromised. So the hand will remain in prone posture. You see here? You are telling that pronators have become more powerful? Yes, pronators have become more powerful because supinator has been compromised. This is called as policeman tip hand deformity. Shoulder in adduction and medial rotation. Elbow in extension. And the radial ulnar joint, it is in pronation. This is called policeman tip hand deformity. Some muscles became more powerful, bringing the deformity. This is a question which is PGI Chandigarh question, year 2012, and multiple answers. Tell me which is yours, because it is asking upper trunk lesion. If it is a lesion of the upper trunk, I think I already have seen some details. I'll see now. Supination of forearm. I think supination was lost. This is wrong. Then external rotation of arm. I think external rotation was lost. This is wrong. Inability to initiate abduction. Yes, abduction was a problem. That is there. And what about the sensation on the medial? Not medial. It was lateral. It is not medial. It was lateral. This is wrong. And what about the deltoid? Yeah, that is there. So you mean to say you have double answer? Yes, this is Erb's palsy. In Erb's palsy, there will be inability to initiate the abduction because supraspinatus supplied by C5, C6 suprascapular nerve compromised, and deltoid is compromised due to axillary nerve injury. So abduction is again a problem. So these are the 2 answers. Yes, they are the 2 answers you have to keep.